I would like to welcome everybody to this Health and All Policies Equity Speaker Series event. The Strategic Growth Council coordinates state actions to realize healthy, thriving, and resilient communities for all Californians. Our approach is grounded in equity and raising the voice of communities across the state, and really rooted in collaboration. And I think this event is an excellent example of that. Along with our equity approach, I do want to start this event with an acknowledgement that we are on the traditional territory of the Nisenan and the Maidu and the Wintun people. As part of our work to promote equity in government, it's important that we acknowledge being on Native land. The genocide of Native peoples is often overlooked, even in places and spaces that are explicitly looking at racism. So these statements are a step towards correcting the stories and practices that erase Indigenous peoples' history and culture. And it's important for all of us to be exposed to the names of the traditional Indigenous inhabitants of the lands we are on, and to take steps in increasing awareness and action. In that light, I recognize the continuing connection that Native people have to the land, waters, and culture, and pay my respect to their elders past, present, and emerging, as well as any tribal members who are here today. So I'm very excited to be partnering with Health and All Policies, which is a partnership of the Public Health Institute and the California Department of Public Health. We work together on the Racial Equity Capital Collaborative and a number of other partnerships. And so it really is a pleasure to be co-presenting this event with them today. I'm also very excited to welcome our new State Surgeon General, Dr. Nadine Burke-Harris, and welcome our new Health Officer and Director of the Department of Public Health, Dr. Sonia Angel, who you'll hear from both of them. We're very excited to have these new partners in our work. So as we look out at the room today, very excited, we have a number of state agencies and departments represented, and this is just indicative of the work that I think the Health and All Policies team has done over the last decade, which is to bring together so many state agencies and departments in doing the work. It would be great to get a sense of folks who are in the room today. How many have been involved in the Health and All Policies task force? I see, yay. Quite a few hands going up. And who else has been involved in the Capital Cohort or the Racial Equity Capital Collaborative? Even more. Great to see that. So thank you all very much for your continued participation and work in this space. We have an exciting couple of hours coming up. I do want to first start by thanking so many people whose work went into organizing this event. The Health and All Policies team, staff at the Health and Human Services Agency, the Department of Public Health, Office of the Surgeon General, and many of our other partners. So just thank you to bringing us all together today. I'm now going to turn this over to Julia Kaplan, who directs the Health and All Policies team at the Strategic Growth Council and the Public Health Institute, to go over some of the logistics for the remainder of our time.
Thank you so much, Louise, and welcome again to all of you. One of my favorite things in my work is getting to stand in front of groups like this and look out and just see the energy and the love and the caring and the dedication of all of us and all of our colleagues working in state service. So it's really a pleasure and honor to be here with all of you. My name is Julia Kaplan. I'm with the Public Health Institute, which is a nonprofit organization that partners closely with the Strategic Growth Council, the Department of Public Health, and many other organizations in state government on a variety of projects, but in particular on the Health and All Policies work and the work around racial equity in state government. And my role right now is to take care of a few housekeeping items. So restrooms are out the door to your left past the elevators. I think that was the main housekeeping item, but it's important. Take care of yourself. I also, we put this list up of the departments in the room, and initially Louise and I had thought, wouldn't it be fun to go down the list and have each of you cheer for your department? And then I realized it was actually going to take a long time to do because there are so many. And I think it's really unusual to find spaces in state government where we have such a diverse array of professional backgrounds coming together around shared values and shared work. So I really want to note that. And I want to give some thank yous specifically to Jim Sunan with the Health and Human Services Agency and Kate Powers with the Office of the Surgeon General for support on this work. Also Shirley Fong at the Department of Healthcare Services, our colleagues at the Department of General Services who are here doing tech and setup, the entire Health and All Policies team, folks who are out at registration, especially Holly Nickel, who runs our racial equity work and has really been the brains and the brawn behind this whole event. So thank you, Holly. The format for today, we're going to hear some opening remarks and background from Dr. Angel with the Department of Public Health. And then Dr. Angel will introduce Dr. Burke Harris. Dr. Burke Harris will give a talk, which we're very excited to hear. After her talk, you will all have a few minutes to debrief, to turn to somebody next to you and just kind of talk for a few minutes about what struck you about the talk. And then Dr. Burke Harris and I will sit down here on the stage for a conversation. I have a few questions to ask her, but we're also inviting you all to ask questions. So the way that you can do that is we have note cards. Those were available at registration. Meredith is holding them up in the back as well, and a couple staff will come through and pass them out in case any of you didn't get one and would like one. You can write questions down on there. We would really like it if you would also write your department and your first name. I think it's just nice for us to get a sense of where the questions are coming from, but that's optional. And then we will sort through those, and some of those questions will be asked during the Q&A. I'm going to turn things over to Dr. Angel in just a moment. Before I do that, I want to take this opportunity to say how thrilled I am that we not only have a Surgeon General focusing, but first off, that we have a Surgeon General, period, and that we have a very special and really great person in this role of Surgeon General, and that she's focusing on adverse childhood experiences, which we'll learn more about in a few minutes. And I also want to express my happiness and excitement that we have a new state health officer and CDPH director who brings deep experience addressing health inequities and doing proactive work to advance social determinants of health through a health and all policies approach. So please join me in welcoming Dr. Sonia Angel.
Great. All right. So this is such a treat to be here. I am now barely 30 days into my job, and it is an honor that my first public appearance is here today, introducing somebody that I've admired for so long and have known her work for so long, and to be in front of all of you really focusing on one of the most fundamental issues around advancing health, which is addressing racism, and which is addressing health inequities that are associated with it, and which is ultimately about bringing us all together to a place where we can all experience the benefits of good public health and good health. I first learned about Dr. Burke Harris's work when I was at the New York City Department of Public Health, and we were developing a special initiative to focus on the impact that our criminal justice system was having on our communities, largely communities of color, not only on the individuals who are directly touched through perhaps incarceration or arrest or community supervision, but including also their families and their children. And when we were looking for quantitative ways to understand the long-term impact of a criminal justice system, which is fundamentally racist in the way it's implemented, we recognized this work as a way to really start understanding the long-term effects of the system on our children. And it was such a special moment when I came across this work, because here we had a way to measure and talk about it in a very evidence-based manner, which brought the humanity of the experience directly into epidemiologists' hands, doctors' hands, physicians' hands, and the community's hands. And so I want to thank her for that initially. And I'm also so pleased to understand once I arrived here, to see the remarkable development that's occurred over time here with a focus on equity through the GARE, through the capital cohort, and through the health and all policies work, and the beautiful linkages that it has occurred not only across the department, but all the way up through to the governor's office, which I think is one of the key reasons that I wanted to be a part of this department, of this agency, and a part of this administration, because equity is a fundamental part of creating a society that's good, that functions well, and where all communities have opportunities to flourish. So because all of you in this room have been a part of this conversation, I thought about, but then I decided not to put up that slide of the kids trying to look into the park. Do you know the one I'm talking about that defines equity? But I did want to bring perhaps another way to really emphasize how important equity is to health. So I'm going to share with you this slide. So how many of you remember Sisyphus? Do you remember that story maybe back? Okay, so Sisyphus was, in part of Greek mythology, was a very bad king. And Zeus got pretty angry with him. And as a result, to punish him, he created for eternity a situation where Sisyphus had the responsibility of pushing this boulder up the hill, but the boulder, as soon as it got to the top, would fall back down. And I think this slide right here really reflects that idea of the impossibility of improving health if systems are not aligned with individual effort, right? So on the left-hand side, I have a few of the attributes of what it takes for an individual to make healthy decisions and to be able to be healthy. The individual has to have a culture that embraces different practices that result in good health outcomes. The individual has to have attitudes and beliefs personally that embrace behaviors that result in good health outcomes. They have to have skills, they have to have knowledge, they have to have time to be able to exercise those, and they also have to be able to afford whatever resources you need to be able to do that, right? So if you like to cook, then you have to have the money to be able to buy fruits and vegetables. But even if we invest in, even if a community or an individual has all of those assets, if the community around them doesn't let them exercise those assets, it will be like pushing a boulder up the hill forever. They'll never be able to exercise those practices that they know are so fundamental because the community around them doesn't offer them the choices to do that. So if you know that cooking fruits and vegetables at home is the best thing to create a nutritional meal, and if you have money to do it, if you go into your neighborhood and you can't buy fruits and vegetables, if you have a job that doesn't give you the time to get home in time to cook fresh fruits and vegetables, you will never be able to do that. In short, you can't make healthy choices if you do not have healthy choices. This is really about creating healthy choices, but not just for a few. Healthy choices for many. And so the last couple slides I just want to show you is another reason why I think Dr. Burke-Harris's work is so important. This slide comes from some work that I did with the Lancet Commission on Hypertension. And we were thinking about ways to talk about how to reduce hypertension in populations over time. And so we used the life course approach. So on the left-hand side, you see going across the horizontal from childhood, early adulthood, middle age, advanced age, and the elderly. And on the vertical, you'll see sort of the stages that people can go through, from being healthy to having uncontrolled blood pressure, to having organ damage, or to having cardiovascular disease. And let me say that hypertension is one of the leading risk factors for death in the world, in the United States, and in California. So this is just one simple disease, one simple condition. And what you'll see is, while the vast majority over time develop hypertension over their life course, it doesn't have to be that way. But it doesn't have to be that way only if we change the environment around us so that we aren't exposed to very high levels of sodium, so we get enough exercise, so that we don't become obese. So all of those things that we need to be healthy are there. So this was what we put into the article in Lancet. This was the design. And so I went to New York City, and we were talking about hypertension, and we were with a bunch of community stakeholders, and I showed this slide. And the conversation quickly evolved. And what I realized was this. The reality is we had messed up the design of this because we did fail to recognize that the average is not everyone. And so when we think about moving people forward, when we think about pushing that curve down, we have to appreciate that some people are starting much further back. And this is where Dr. Burke-Harris's work becomes really, really essential. Because to reach the ideal, we have to be clear about where the starting point is. And the starting point, if we're really going to push the curves down, is back here at childhood. It's back here really understanding that milieu of experiences that ultimately create poor health. But we can change that. We can only change that, though, if we really understand what's going on. And what we measure is the way we change the outcomes, because we can't change things if we don't know they exist. And Dr. Burke-Harris has demonstrated to us that these issues do exist, particularly for children, and that trauma in particular is one of the things that leads to poor health in adults. And hypertension is one of those poor health outcomes that comes from that experience of early life. So without further ado, I want to introduce Dr. Burke-Harris. She's an award-winning physician, researcher, and advocate. As you know, she's been dedicated her entire life to this work, starting back at Bayview Health Center in one of San Francisco's most underserved neighborhoods, where she founded the Center for Youth Wellness and subsequently grew the organization and as an individual into a national leader, really focusing on adverse childhood experiences, how to document, how to raise awareness around them, and really how to transform society so that our communities no longer have to have these unfair experiences. She founded and led the Bay Area Research Consortium on Toxic Stress and Health to advance scientific screening and treatment of toxic stress, and we are so deeply fortunate and thrilled to have her as our Surgeon General, and I appreciate the opportunity to introduce her.
Thank you so much. It is such a pleasure and an honor to be here. And I'm trying to, oh, this is working. Yay. I'm gonna put this down. And that way I can use both my hands because I'm Jamaican, so I kind of very expressive. Thank you so much for that very, very warm introduction. I feel like I have to say I only have one edit to my bio, which is that it says, you know, she did this and she did that and da-da-da-da. And we know that the reality is that it takes a whole team of people, right, to do this. And it's not she did, it's we did, right? And we are doing. And all of the folks in this room are a part of this larger we who are slowly but surely moving us forward and advancing both the care and the systems that we're able to provide to ensure that we actually realize a vision of health and health equity in the state of California. So I wanna start off by asking the question, how many folks here are familiar with the term adverse childhood experiences? Oh, yes. And how many folks are familiar with toxic stress? This is awesome. How many folks here have heard me speak before? All right, don't give it away for your neighbors, right? Because, you know, there's always some greatest hits in there. So this is fantastic, right? A decade ago, I would be in a room this same size and ask how many folks have heard of adverse childhood experiences, and literally 3 hands would go up, right? And I always love doing that because it's always a measure of the progress that we've made. But as you all have heard, in January of this year, I was our governor issued my favorite of all of his executive orders, and this was the executive order that created the role of Surgeon General for California, and specifically, you're not intended to be able to read this because the print is really tiny, but specifically, I just want to call out a couple of lines. He says, whereas California faces serious health challenges rooted in early social determinants of health, and whereas these challenges are not only serious, but inequitable, disproportionately impacting low-income Californians and communities of color. And whereas some of the most pernicious but least addressed health challenges are the upstream factors that eventually become chronic and acute conditions that are far more difficult and expensive to treat. And then he goes on with the rest of the whereases to say it is hereby ordered, right, that we're creating the role of Surgeon General, and that this Surgeon General shall marshal the insights and energy of medical professionals, scientists, and other academic experts, public health experts, public servants, that's all of us, right? And everyday Californians to solve our most pressing public health challenges, right? That's what we're doing here today. And coming into my role as Surgeon General, I really worked together with the governor's office to create several key priorities. And these for me are health equity, early childhood, and adverse childhood experiences and toxic stress. And it's really been my pleasure and my privilege to work with leaders across state government on advancing all of these initiatives. But the area where I feel like I really get to take the most of a leadership role is around the issue of adverse childhood experiences and toxic stress, right? We're working closely in coordination on health equity and really working with our partners. But the place where there was kind of less of a preformed effort was really this effort on ACEs and toxic stress. And so I want to share with you all a little bit about what that looks like, what we've been doing, and the why and the what of what we're doing around adverse childhood experiences and toxic stress in California. So I know that all of you, right, on November 5th, 2019, like me, you probably bounced out of bed in the morning, checked your email, and saw that the CDC had issued the Morbidity and Mortality Weekly Report, right? Featuring adverse childhood experiences for a public health person, making the MMWRs like cover of Vogue, right? Like, I was beyond myself. But in all seriousness, when the CDC issued this report less than a month ago, really highlighting the burden of adverse childhood experiences on health in the U.S., right? And when they said that preventing ACEs could reduce a large number of health conditions, up to 21 million cases of depression, up to 1.9 million cases of heart disease, up to 2.5 million cases of overweight or obesity, right? That was really a watershed moment. And it's a sign of how far we've come. Because the original ACE study, right, was published by the CDC and Kaiser Permanente now, over 20 years ago, right? And after that publication came out, what happened? We did not get the cover of the MMWR, right? It was a whole bunch of nothing. It was like silence. And it's interesting, I've talked with the principal investigators of both from the CDC and Kaiser about that. And when this original research came out, it was something that a lot of people weren't totally ready for, right? And so what's happened over the past 2 decades has really been extraordinary in terms of recognition and understanding of what adverse childhood experiences are and how they impact our health. So I'm going to talk a little bit about that original research and what the implications are, and then what we're doing about that. But before I jump into that, I want to start by holding an opportunity and holding a space to let people know that, when we're talking about adverse childhood experiences, we're not talking about some other folks in some other room somewhere else. And we're talking about difficult and frankly, sometimes traumatic experiences that have happened in childhood. So if anyone feels like they need to excuse themselves or take a minute, please go ahead. So when we talk about the original 10 adverse childhood experiences, these include physical, emotional, and sexual abuse, physical and emotional neglect, or growing up in a household where a parent was mentally ill, substance dependent, incarcerated, where there was parental separation or divorce or domestic violence. And what the original CDC Kaiser ACE study found, right, was number one, that ACEs are extremely common. So 2/3 of their population had experienced at least one ACE. 1 in 8 folks had experienced 4 or more. Here in California, we see that 63.5, according to our BRFSS data that's collected by CDPH, 63.5% of Californians have at least one ACE. 17.6% of Californians have 4 or more ACEs. And if you look at this slide, on your right-hand side, you'll see the prevalence of ACEs by race and ethnic group, right? And we'll see for Caucasian, African American, Hispanic or Latino, or Asian Pacific Islander. And I'll tell you, this data was based on 4 years of BRFSS data that was collected and analyzed jointly through Public Health Institute and my former organization, the Center for Youth Wellness. And I was shocked when I saw this data. I was like, what? So first of all, we see the highest prevalence in the Hispanic or Latino community. But what we also see is like there's very surprisingly little difference. And for me, as a Black female immigrant working in a community like Bayview Hunters Point, I was shocked. But what was interesting about this, and I think this was powerful, I think it was a powerful tool thing that came up in the ACE study, right? Is that these questions don't ask about discrimination. They don't ask about being separated from a parent or caregiver because of deportation or migration. They don't ask about being ostracized from your immediate family because you're LGBTQ, right? They don't ask about any of this stuff. And so in a way, it's a very interesting thing. We see these very similar prevalence. And in the Kaiser study, right, their population was 70% Caucasian, 70% college educated. But there's something real sneaky in there, right? I'm going to get to this in a second. I'll get to the sneaky part. But it's actually this. It's really fascinating piece. They don't ask about those questions, but they do ask about common adversities. And the reason that they asked about these common adversities was because these were the things that were prevalent in the community that, the Kaiser San Diego community where this research was done. What we do see is that ACEs tend to be measurably higher in low-income communities. So when you look at, for example, the prevalence of 4 or more ACEs is double for communities that are low income, making less than poverty or less than $15,000 a year compared to communities that are making more than $50,000 a year, right? So we definitely see that difference. So number one, we know that ACEs are incredibly common. And the second finding was that there is what they call the dose-response relationship between adverse childhood experiences and many, many, many common health conditions, right? So here we have the 10 leading causes of death in the United States of America. And I used to have this slide, and I would say ACEs are associated with dramatically increased risk for 7 out of 10, right? And then I'd be working with my research team, and we're like, oh no, it's 8 out of 10. Then we get another report, a meta-analysis from somewhere. So now we're at 9 out of 10. I'm sure sometime soon we'll find out about, we'll get some rigorous, robust data about the association between ACEs and influenza or pneumonia. But we see it's, for 9 out of 10 of the leading causes of death, right, we see a dramatically increased risk. We're talking about double the risk for heart disease, more than double the risk for cancer, significantly increased risk for accidents, more than triple the risk for chronic respiratory disease, and so on and so forth. But the piece that is critically important, and the piece that I take away from this when we look at the science, right, is that we recognize what the risks are when we recognize what the risks are. We recognize why this is so important, right? Because this list includes some of the biggest drivers of healthcare costs in the United States of America, right? But we also recognize that ACEs are not destiny, and that with intervention, we can make a significant impact to improve outcomes. So how are we going to do that, right? When we think about how to do that, it's important for us to take a look at the biology of adversity. Because for myself as a scientist, anytime we want to get to the bottom of something, you guys know this, so early 80s, right? Folks are coming into the emergency room, really, really high rates of these, tuberculosis, right? And doctor said, oh, tuberculosis, I know that, right? Here's the prescription, send you out. And then they were coming in with crazy rates of this, uncommon pneumonia, pneumocystis pneumonia. And doctors were like, okay, I got to look that up, but I'll, write your prescription, send you out. And then people were coming in with this, weird skin lesions, Kaposi sarcoma. And say, oh God, I don't know that one that well, but I'll refer you to a colleague, right? Because I know someone who knows about that, right? And then we'd send patients back out. And what happened? They kept coming back, and they were getting sicker and sicker and sicker. Because the prescription to treat the TB and the pneumocystis, those didn't get to the root cause. They were treating the symptoms. But the root cause, right, was a virus, and not just a virus, but a retrovirus. And when we were able to use the science, the biology, we were able to develop antiretrovirals, which ultimately led from 6-month mean mortality, right? 50% of folks died within 6 months of diagnosis, to now on standard antiretrovirals, life expectancy greater than 50 years, right? We did that in 3 decades. But that came from rigorously applying the science of prevention and intervention and understanding the mechanism so that we could dramatically transform our public health outcomes. So when we want to understand how ACEs lead to all of these negative health outcomes, understanding the biology is really important. And it works a little something like this, right? You're walking in the forest, you see this guy. I hope you're at least a little scared. It's supposed to activate your stress response, right? What happens? Our amygdala, right, the brain's fear response, sounds the alarm. And it signals our body to release a flood of stress hormones, right? So we have adrenaline and cortisol that leads our hearts to beat stronger and faster, right? Our pupils dilate, our airways open up, and we are ready to either fight this bear or run from the bear. Now, if you were to think about it, fighting a bear wouldn't seem like a good idea, would it? No, look at him, he's big, he's got teeth, he's got claws. So that's why our amygdala, right, the fear response, actually sends projections to the prefrontal cortex, the part of the brain that's responsible for judgment and impulse control and executive functioning, and it turns it way, way down. Because if you're in a forest and you're seeing a bear, you don't want impulse control to get in the way of survival, right? And instead, what it does is it turns up the noradrenergic nucleus of the locus ceruleus, or as I like to call it, the part of the brain responsible for, I don't know karate, but I do know crazy, right? This is the within the brain stress response. It gets us amped up. I see some people like that, yeah. And the other thing that happens when you activate your stress response is that it also activates your immune system, right? So that if that bear gets his claws into you, you want your immune system to be primed to bring inflammation, to stabilize that wound so that you can either live long enough to either beat that bear or get away. It's brilliant. It was designed over millennia to save our lives from a mortal threat. But the problem is what happens when that bear comes home every night. And this biological process is activated over and over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to the repeated activation of the stress response because their brains and bodies are just developing, right? So high doses of adversity in childhood actually changes the structure and function of children's developing brains, the developing hormonal systems, their immune system, and even all the way down to the way their DNA is read and transcribed, their epigenetic regulation. And even though the ACE study was done in adults and we see the association with all of these long-term health outcomes, when in looking at all this research, as a pediatrician working in one of San Francisco's most underserved communities, I was like, how is this showing up to my kids in front of me every day? And what we see is that in childhood, high doses of adversity, right? Like the signs and symptoms. Oh my God, I almost forgot something. Hold on, I'm gonna go back for a second. So this biological process, right? The changes to the brain, immune system, hormonal system, way DNA is read and transcribed, that is what is now called the toxic stress response, right? And guess what? This is fascinating. This is where the sneaky part comes in. Because ACEs aren't the only thing that put an individual at risk for toxic stress. So if your immune system is activated because of discrimination, right? Because of you're a kid and your parent just got deported. If you're, for whatever that causes, it activates the same biological process. And that is really important and fundamental for us to understand and recognize as we're moving forward in our equity work. And that's something I'm going to talk about a little bit further. But we can now recognize some of the health and behavioral outcomes in children, everything from developmental delay and poor growth in babies to increased risk of asthma and pneumonia in school-age children, all the way to increased risk of teen pregnancy, teen paternity, autoimmune diseases as kids get older. Not only that, right? When we understand that this is a biological response, it turns out that mom's ACEs, right? The history of adversity that mom experienced in her childhood can also put her at increased risk for negative prenatal and perinatal outcomes. And so that continues forward as we see the whole range of adult health outcomes, everything from injury and fractures to mental health conditions like depression, anxiety, or suicidality. I talked about the pregnancy outcomes, infectious disease like HIV and sexually transmitted infections, cardiovascular risk, increased risk of substance dependence, and poor educational and vocational outcomes. Right? So when we understand, right, the biology of how repeated activation, overactivation of the stress response without adequate buffering care, right, leads to long-term changes, then we can use that science to break the cycle. And the other thing that we understand about toxic stress, so you heard me talk about, we now know this as a toxic stress response. Our stress response is characterized in three ways. There's a toxic stress response, but there's also, remember that our stress response was designed to save our lives from a mortal threat, right? So if you have a threatening or scary situation and you have, and then that stressor goes away, you can recover quickly with the body's natural coping mechanisms. If the stressor is more prolonged or more severe, then you actually require nurturing, buffering care to recover, right? And so what we see is that homeostasis recovers through the buffering effect of a caring adult or other interventions, right? We know this. As a mom of 4 boys, my husband and I have 4 boys, right? When something terrifying or scary happens to one of my boys, what's the first thing I do? I grab them up, I hug them up, I love them up, right? I make them know that they're safe. I make them know that they're okay, even if there's a difficult or a stressful situation. And by providing that safe, stable, and nurturing relationship, right, it's not just that it helps my kids feel better. We actually now, we have all this research about how the stress response gets activated. We have all this research about how our body has also evolved these mechanisms to counteract the stress response, right? So we see that safe, stable, and nurturing relationships for kids who are randomized into high-quality nurturant caregiving, right? Kids who are exposed to adversity initially and then randomized into high-quality nurturant caregiving. On MRI studies, they actually see normalization of the white matter tract development in children's brains, right? Like safe, stable, and nurturing relationships and environments are actually physiologically healing from the inside out. We see regulation of the immune system through things like meditation, or how social support protects against the rise in infection risk associated with the increased frequency of conflict. Right? We see that, when I snuggle up my kids, it actually helps to release oxytocin in their bodies. And that oxytocin inhibits the stress response, enhances bonding, protects against stress-induced cell death, has anti-inflammatory effects, and enhances metabolic homeostasis, right? The ability of the body to achieve that biological balance, and protects the lining on the inside of our arteries, right? So as we learn more and more about the science of how what factors can really help to be these buffering protective factors and counteract an overactive stress response, right? We have the ability to deploy this science to intervene in the toxic stress response. And in fact, how many here have heard about the Lick Your Pup study? Michael Meany, McGill University, right? So there's a researcher at McGill University who is looking at this, because what we see is these biological processes happen across species, right? They happen from humans all the way down to apes and mice and cattle, all the stuff, all the way down to mice, even in certain species of fish, right? And what's fascinating about this is a bunch of researchers took two sets of rat pups, and they stressed them out, and then they gave them back to their moms. And what they found was that some moms kind of naturally did more nurturant caregiving behavior, and some moms, not so much. And here's what was fascinating. When they tracked those rats through their lives, and when they actually gave them all executive functioning tests, all of this stuff, the rats who had more nurturing caregiving, what do you think happened? They scored better on the test of executive functioning. They were more resilient to stress, and in fact, their biological stress response had a more normally functioning ability to turn itself off after a stressor. And what they found was that these factors were associated with markers on these baby rats' DNA, right? When the moms did lots of nurturant caregiving, those baby rats had a certain DNA markers. When the moms didn't do a lot of nurturant caregiving, those baby rats didn't have these DNA markers, and it was associated with different performance. And then they did something crazy. They took these baby rats, and for the next generation, right? Because the other thing is that if you had these markers on your DNA, you were also more likely to grow up to be a mom who did lots of nurturing caregiving, right? But then the next generation, they took the rat pups and they switched them at birth. So the pups who were biologically from a mom who didn't do much nurturing caregiving, they gave them to a mom who did a lot of nurturing caregiving. And what do you think happened? Those rats then performed better on the executive functioning test. They had a more normally functioning stress response system that turned itself off normally. And when they looked at their genetic markers, those rats had the genetic markers of the moms who raised them, their foster moms, not their genetic moms. So our ability to intervene, right, goes all the way down to our DNA. And when we think about how we buffer the toxic stress response, right, some of the key factors that we see that really have the best evidence is sleep, exercise, nutrition, mindfulness, mental health, and healthy relationships, right? These are some key factors that help to reduce stress hormones, reduce inflammation, and enhance neuroplasticity, right? So now that we're armed with the scientific information that helps to provide us with a little bit of a roadmap, here in California, so when you get appointed to be the first state surgeon general for the great state of California, I figure I gotta go big or go home, right? I say that, and I'm kind of joking, but when we recognize this unique opportunity with an administration that really gets it, and literally you saw the governor's executive order, right, that created this role. For me, it felt really important to be ambitious, and not just to be ambitious. It's not about being ambitious for myself. It's about being ambitious for our kids. It's about being ambitious for the next generation. And I think that we have an enormous opportunity. And so I've created a goal for California that we will cut adverse childhood experiences and toxic stress in half in 1 generation. Thank you. I know it sounds like a lot, but I'm going to tell you, you guys, we've done this before, right? When we look at smoking, for example, if you look at teen smoking between 1996 and 2016, teen smoking went from 25% to 3.6% among 12th graders in 20 years. That's 1 generation, right? All we got to do is cut ACEs in half. This should be easy. When you look at maternal mortality, this is actually another excellent example of the power of a public health approach, right? When we look at maternal mortality, in California, we created the CMQCC, the California Maternal Quality Care Collaborative, right? And by deploying these techniques of standardizing how we're approaching maternal mortality, really tackling and taking on this issue, California has reduced maternal mortality by 55% since the implementation of the CMQCC, while nationally, maternal mortality continues to rise, right? We can do this. And the way that we do this is by looking at the evidence. So earlier this year, the National Academies of Sciences, Engineering, and Medicine released the Vibrant and Healthy Kids report, aligning the science, practice, and policy. And what this report tells us, right, this is one of these consensus reports from the National Academies, reviewing all of the evidence. And what it tells us is a couple of things. Number one, intervene early. The preconception through early life periods are foundational for healthy development across the life course. Biologically, a number of critical systems are developing, and humans have high plasticity during these life stages, right? So number one is intervene early. Number two is address systemic and structural factors. Individual experiences within systems vary dramatically based on racial, cultural, or other personal characteristics. And the effects of these systemic factors are by no means individually deterministic, but they do help to set the odds. And when different odds play out over time, they generate systematically different health outcomes. A health equity approach requires systems to change in ways that improve opportunities for good experiences and reduce the odds of adverse exposures. And what the National Academies did is that they created this framework, right, recognizing that biology that I talked about, the activation of the stress response in the middle, but recognizing that what shapes our biology is our social connections, our family cohesion, our caregiver well-being, our healthy child development. And that, in turn, right, is shaped by our healthy living conditions, our healthcare system, our early care and education system. And all of that is shaped by structural inequities, socioeconomic and political barriers, and they play out on a generational standpoint, right, through intergenerational effects. And so as California is thinking about how do we systematically and effectively seek to meet that goal of cutting ACEs in half, we recognize one important approach is to, number one, establish primary prevention, right? Primary prevention is prevent it from even happening to begin with, right? By addressing systemic and cultural factors and deploying a coordinated public education campaign. Because I will tell you, just as 10 years ago, I'd go in a room and half the hand, 3 hands would go up. Still, when we walk outside and we go to the grocery store, if you ask the guy who's checking you out at CVS, hey, what's diabetes? He'll be like, diabetes? That's when you got the high, you got the sugar, right? You got high blood sugar. And you ask him, hey, what's ACEs? What's toxic stress? He'll be like, what are you talking about? Right? How are we going to protect our kids? How are we going to protect the next generation? How are we going to help our families heal when, generally speaking, there's still an incredible amount of public awareness that needs to happen? We're also systematically, and when I say also, I mean on Wednesday, systematically deploying broad-scale screening to enable early detection and early intervention of ACEs and toxic stress. We have to interrupt the vertical transmission, right? We know that ACEs are handed down from generation to generation. And the way that we interrupt that vertical transmission of ACEs is by not only screening children, but also screening adults and ensuring that adults have the tools that they need to break that intergenerational transmission, that we're supporting parents and caregivers so that they're not handing down their ACEs to their kids. I'll tell you, I went to a conference, it was the National Crittenton Foundation, and they were using this ACEs framework and teaching all of the young women. It was a framework for pregnant and parenting young women. And I cannot tell you how many young women at that conference came up to me and said, Dr. Burke-Harris, I just have to tell you, I have 10 ACEs, but my kids have 3. Right? That's powerful. That is breaking the intergenerational cycle. We also have to coordinate and strengthen our network of referral and treatment systems to make them more effective, accountable, and easy to navigate for children, adults, and providers. And finally, we need to advance the science of toxic stress to identify potential therapeutic targets and improve efficacy of interventions. So what we see happening now is almost $200 million invested into our early learning and care workforce and infrastructure. This administration has been leading the way in investing in initiatives that support families to set the odds for health, right? And that goes in early childhood, in after-school care and education, in state preschool, and in creating a master plan for early learning and care. We see cross-sector coordination. So my office, the Office of the Surgeon General, has been convening the ACEs Reduction Leadership Team, which is a collaborative effort of leaders across the Newsom administration to develop a multidisciplinary plan to cut ACEs and toxic stress in California in half in a generation. And that includes representatives from the governor's office, from all of the departments within Health and Human Services, the Department of Education, law enforcement. Beginning January of 2020, every Medicaid provider will get reimbursed, will get paid, right, for screening for adverse childhood experiences. And for once, this is like, we always say, hey, we got to do this. Hey, we have to address equity in this way. We have to address equity in that way. We have to we have to do early detection and early intervention on ACEs. And for once, it's not an unfunded mandate, right? the administration put $40.8 million to reimburse providers and an additional $50 million, right, plus a potential federal match to train providers on how to screen and how to respond with trauma-informed care. And finally, I'm going to give a little shout out to my colleagues in precision medicine up in the second row here, where for the first time ever, right, as part of a precision medicine initiative, we've allocated $9 million for research, demonstration projects that address the health impacts of ACEs using precision medicine approaches. And the Precision Medicine Initiative, what they said was, hey, listen, our researchers, they do a ton of time, they spend a lot of time in the lab and the research and doing this bench work. They actually have to partner with a community organization in doing this research so that it is inclusive and equitable. That's our precision medicine research. So that RFP goes live tomorrow, so feel free to shout it from the rooftops. Let any researchers that you know about that. And part of the reason why that's so important and such a critical part of an equity agenda, when we talk about equity, I think a lot of the times when we talk about equity, we think about organizing. We think about changes in policy. We think about changes in practice. We think about raising awareness, right? And speaking truth to power. But don't forget my peeps, y'all, because when we look at the death rate from HIV/AIDS, right? When we see, when I talked about how dramatically the death rate from HIV/AIDS declined after the development and broad-scale implementation of antiretroviral therapy. The other piece of that, which is super powerful, let me see, I don't know if I have, does this have a laser pointer? Let's see, does that, no? Okay, I'm just gonna point out, that top line is the death rate for African-American males, right? That next line down is the death rate for Hispanic males. And sometimes when we think about tools for equity, when we think about tools for improving health and improving outcomes for our Black and brown and LGBTQ partners and communities, do not forget biomedical research, right, as an instrument, a powerful instrument for equity as well. And that is what we're hoping to do through the Precision Medicine Initiative, because I believe that when we have better interventions, more effective, that have been rigorously evaluated, right now, a little 5-year-old kid sitting in kindergarten, or a 4-year-old kid sitting in preschool, if they demonstrate symptoms of a toxic stress response, if they have a poor impulse control or an overactive stress response, they are 4, 5, 6 times as likely to be kicked out than one of their white counterparts. And we have to address the environment, the structural issues, the structural inequities, but we also have to advance the efficacy and rigor of our treatments to ensure that all people have equal access to excellent interventions for treating toxic stress. The CDC, in their big mortality and morbidity and mortality weekly report, one of the things that they put out there is this recognition of what would our healthcare landscape look like if we could dramatically reduce the prevalence of ACEs in the United States. And they projected with their analysis a 44% decline in depression, a 27% decline in COPD, a 24% decline in asthma, and so on and so forth for kidney disease, stroke, cardiovascular disease, cancer, etc. A 33% decline in smoking, a 15% decline in unemployment. When we think about these big initiatives, people say, oh, well, how can we afford to do it? We can't afford not to do it. And the good news about this is, frankly, is that it doesn't really matter whether a person is on the right side of the aisle or the left side of the aisle. It doesn't really matter where, what your politics are, right? I think that when we're looking at these issues of the dramatic decline in common health conditions and common drivers of healthcare costs, that's something that everyone hopefully has some kind of intrinsic motivation to move forward. But as we're doing this work, the last thing that I will say is that, coming back to the comment I made at the outset when I started talking about ACEs, when we're talking about cutting ACEs and toxic stress in half in a generation, right? It sounds short and ambitious and big, but 20 years is a fair amount of time. And we need all of you to be part of this work. And that means that we got to be practicing self-care, right? Because as we are out there implementing this work, talking about it, raising awareness about it, we also have to recognize that this is difficult stuff. And I think for many of us, we come to it because there's some kind of personal connection, which I think is actually really important. When I first started doing this work, someone asked me the question, well, 2/3 of Americans have at least one ACE. How do you think you're probably ever going to solve that? That's too big. We'll never fix that. And I was like, That's actually where you turn what seems like a weakness into a strength, right? Because if 2/3 of Americans have at least one ACE, that means 2/3 of people know what this feels like, right? It means that every single one of us is no more than 1 degree of separation from a loved one who is struggling with the long-term impacts of ACEs. And that means everyone's got skin in the game. So I want to thank you guys for your kind attention. I believe we can do this. I believe we can cut ACEs in half in a generation, and I look forward to doing it with you. Thank you.
Thank you so much, Dr. Burke-Harris. That was fantastic. What we're going to do right now is, before we transition to a Q&A portion, we're going to give you all a chance to debrief this a little bit. So we're going to take about 3 or 4 minutes. This is a time to do a couple things. One of them is if you have a question that you want to write down and you haven't yet, write those down. If you haven't passed your question card to the aisle, we'll have staff coming through. Please pass those over. And now you have about 3 or 4 minutes to just turn to somebody next to you and have a couple minutes to debrief. What was something from this talk that struck you, that was particularly interesting, maybe something new, maybe you're thinking about something differently than you have before? Go ahead and meet a neighbor if there's somebody next to you that you haven't met, and then we'll reconvene in just a couple of minutes. Thank you. We got some excellent questions from all of you. We've just been looking through them, and they're great, and we'll try to cover as many of these as we can. I actually prepared a few questions myself, but it looks like you all have submitted many of those same questions, so that's great. So I'll just start with a question that I know has been on the minds of a lot of folks. You have a lot of visibility in your role as Surgeon General, and your office is a small office. It's a new office. You're working alongside many partner institutions and a very large bureaucracy. I think you have 4 or 5 staff on your team. when you're fully staffed, you will. So, and in our health and all policies work, we embrace the idea that we need to break down government silos and work together to tackle some of these hardest issues in society, that none of us can actually achieve any of these things working alone. And similarly, we had a question from Nordia at CDPH, which really gets at what I wanted to ask you. How can we as public servants and as your colleagues across state government help you strengthen your goal of cutting ACEs in half in one generation and fulfill the goals of this office? And so it would be great to hear your thoughts about that, particularly with this very cross-sectoral group.
Sure. Coming into office, it was, the question of, what can we accomplish with a teeny tiny office? And I kind of turned the question on its head a little bit, in the sense of I don't really see it as a question of how can you all help me achieve my goal of cutting ACEs in half in a generation. I more see it, for example, in whatever work that you all are doing. I feel like understanding ACEs and toxic stress is an important piece of the equation that has been kind of missing in our strategic coordinated efforts. And so I really see it more of the question of how can I help you all be more effective in the work that you're doing with using an understanding of ACEs and toxic stress and toxic stress in the work that you are doing. So, for example, in my perspective is, for CDE, right, our Department of Education, how can I help folks within CDE be more help educators be more effective, right? And one of the ways that we've been thinking about would be one of the things that the Office of the Surgeon General does a really fantastic job is getting all of the science and like wading through it and connecting that to some of the most effective strategies, and how can we share that with you all? Or are there specific tools that are helpful to you as you're doing the work? I would say the way that this work is kind of mutually reinforcing is in whatever policy you're developing or implementing, whatever program that you're implementing, to be considering, number one, is there some way in which where that program or policy can be part of an agenda that is cutting ACEs in half, or is there an ACE reduction strategy in that policy? And if there's not, how can we help to get one in there, right? Because I think that it takes all of us to get this done.
Great, thanks. And there were a couple of questions that I think were related about the intersections between work addressing ACEs and toxic stress and some of the things going on in our social and political and physical environment. And so there was one question about how are we going to reduce toxic stress when some of the contributors to trauma are government practices and organizations, ICE, immigration policies, incarceration, policing. And there was another question, you can decide if you want to take these together separately, about climate change and the way that climate change is already and will continue to exacerbate adverse events and stress on communities. And so it would be great to hear your thoughts about those intersections.
Yeah, so I think I'll start by taking them separately. In terms of government policies and practices, I think that a lot of them are so this feels so important, right? Because we are government. And so I think that it's really critically important for us to lead by example in this effort. I earlier this year was in DC at a briefing for Homeland Security in about the U.S. immigration policy and the separation of kids, migrant children from their caregivers. Because if you look at the research on toxic stress, that's just the recipe for toxic stress, right? You take stressed out kids and have them in a really stressful, unfamiliar situation, and then take away their caregiver, and that's literally how you develop toxic stress. And so I think that's a really incredibly obvious example. I also think that there are lots of little ways in a lot of the policies and programs that we're implementing every day that have been developed without this understanding or this knowledge, right? That we have an opportunity to put that trauma-informed lens in the work that we're doing every day. And I think that is really important. So I would say government has an incredibly important role to play. And I think we also have, there's an old saying, when you know better, you do better, right? And that's why we're all sitting here right now having a conversation about ACEs and toxic stress, because we then get to take that knowledge back to our departments and our agencies and really inform it and infuse it in the work that we're all doing. In terms of the how climate change impacts these issues, so this is really, there's the funny thing about ACEs and toxic stress, and when you understand, I don't know if any of you all kind of had this experience of once you see it, you just recognize it everywhere, right? It's like when you buy a green Honda Civic, all of a sudden you figure out how many green Honda Civics, you see, you're like, there's another one. But it's really, I think, so in looking at some of the science and the research, when we understand, for example, the impact of toxic stress on our inflammatory responses, right? Then it becomes much less surprising that what we see research that shows that for the same parts per million of air pollution, right? Kids who have high ACEs have greater impairment of their lung function than kids who have no ACEs, right? And so there are these strong intersections. We see the intersection. I was just, as part of my listening tour when I started my when I started my tenure, I was up in Humboldt. Not Humboldt County, Butte County. I was just up in Humboldt County a couple weeks ago. But I was up in Butte County in Paradise where the fires happened, right? And so when we look at the increase in wildfires going along with climate change, and then we also see Butte County is the county in California with the highest prevalence of ACEs, right? And you see the combination between helping that community heal from a fire, from a wildfire, from a natural disaster, it looks and feels different, right? When you're in the county that has the highest prevalence of ACEs in the state of California, right? Because one of the things that we recognize is that when you have that overactivity of the stress response, it also affects how you'll respond to subsequent stressors, right? And not just emotionally. I think that we recognize that we're emotionally more vulnerable, but also physiologically. And so these are the ways in which ACEs and toxic stress, they touch everything that we are doing in our work in government.
Great. Thank you so much. We had a few people asking if you could talk a little bit more about how the screening for ACEs will be implemented, what that's going to look like.
Sure. So the screening will be implemented in primary care. So I think some folks kind of have reflexively might think, oh, you're screening, you're talking about adverse childhood experiences. This might happen in, for example, a mental health setting, right? But one of the things that we recognize is that if you have a mental health diagnosis, it's that's like a late stage outcome, right? Like that's pretty far down the game. The whole goal of early detection and early intervention is to identify someone who is at risk, right? Because of their exposures, but hopefully hasn't developed a negative outcome yet, right? Particularly when we're talking about with kids. And so that's really important. And we actually have a screening tool that so the Office of the Surgeon General worked with experts from across the state and took the current ACE tools and kind of modified and updated them and took some of the best best practices of screening. So it lists the 10 ACEs, and there are actually two versions. So one version, so there's an adult version and a kid for adult medicine and for pediatrics. And then for each of these versions, there's actually an identified and a de-identified, right? Because as you all may guess, for myself, having spent my career working on this and being the principal investigator of the Bay Area Research Consortium on toxic stress and health, which developed one of the tools that we're going to be using statewide, one of the things that we found was that when you have a de-identified version where it lists the 10 ACEs, but specifically asks, right? Don't actually tell me which ones you or your child has experienced, only tell me how many, right? So someone can read the list and say, oh, my child is a 3, or I'm a 6, or whatever the response is. Then what happens is that the physician has the opportunity to understand what their patient's risk is, right? Because we know from all the data what the risk is. But the patient or the parent, if that's the case, doesn't have to unpack everything that has happened to them in that 15-minute visit, right? And actually what the provider can do is connect the patient to a care coordinator or social worker or a mental health professional who can then go and do more unpacking, right? And that was something that was pioneered at my previous center, where I recognized, listen, as a doctor, my job is to listen to that heart and understand if there's a murmur, right? And then if there's a murmur, I can connect you on to, if it's something worrisome, I can connect you on to a cardiologist, right? But I don't have to fix everything. And that's one of the pieces that I just want to highlight, is that part of the reason why there's actually a fair amount of anxiety, right, among primary care providers, among doctors, on screening for ACEs. And part of the worry is like, well, how am I going to fix all this, right? And it turns out that there are some really key things that doctors can do. They can help patients identify that ACEs could be playing a role in their health. A lot of people don't know that. A lot of people still don't know that. And if every doctor in California was saying to a patient, you know what, I notice with your blood pressure or your diabetes, it could be because of your history of ACEs, your body may be making more stress hormones than it should. And here are some ways that you can regulate the amount of stress hormones that your body makes, right? And I'm actually going to check in with you in a month or 2 months to see how you're doing and whether you're implementing these. So that's really how the screening is designed.
Great. And we have a couple of related questions. One of them is, who at DHCS can be contacted with questions about this? So is there a particular branch or division that you're working with?
I think it's acesaware@dhcs.gov. That's just coming off my memory, but you all tell me. There's a team. Yes. So any questions that anyone has about the ACEs Aware initiative, folks can, actually, if you back up, can we back up the slides real quick? I think it's on there. I think it's acesaware@dhcs.gov. Oh, wait, go forward one. No, it went, yeah, there you go. Back. No, that one. Oh, but it doesn't have it on there. I think it's acesaware@dhcs.gov. Sorry.
Great. And you started talking about what providers can do when they identify people who have ACEs, kind of the next step after screening. But can you say a little bit more about that? And yeah, what does early intervention look like? And you also mentioned that part of this is there's some funding to support having a trauma-informed response. So what does that mean?
Yes. So the clinical intervention. So I think one of the biggest myths and one of the biggest challenges that we have to counteract is this notion of, well, even if you identify ACEs, is there anything that you can do, right? And I think that folks have kind of gotten over that in pediatrics. They understand, yeah, of course, there's a lot you can do, especially since a child's brain and body are just developing. But in adult medicine, it kind of still lingers, and it turns out that even in adult medicine, there is actually quite a lot that you can do. And it's easy to summarize it in a simple graphic that says sleep, exercise, nutrition, mindfulness, mental health, and healthy relationships. But I cannot, and part of that is to make it simple and digestible. But I cannot say enough how powerful this understanding and this framework is, right? So a couple months ago, I was doing a podcast with Dax Shepard, he's an actor, right? I was on his podcast. It's called Armchair Expert, and we were chatting about this, and he shared his own ACE score, which was quite high, and we started talking about the list, right? And he also in addressing, in really talking about what factors made such a big difference in his life, he literally made a list of the things that helped to regulate him, right? To help him bring it back into balance. And it included a whole bunch of stuff of connecting with people that he loves, meditating, going and working out, doing things for others. That was actually, but what's powerful about it is really understanding and being able to recognize when that stress response is becoming overactive, and respond to that. And I will tell you that. So in my book, I wrote about a patient that I had who was a 3-year-old girl who had failure to thrive. She wasn't growing. It was one of those, poor growth. And her growth rate was 2.7 centimeters per year, right? And it should have been 6 centimeters per year. So she was growing at half the rate that she should have been. And we did an intervention where we actually did something called child-parent psychotherapy. I connected her to a child-parent psychotherapist, her and her mom. And the most important thing that her mom learned was how the mom's own history of ACEs was interfering with her ability to create a safe, stable, and nurturing relationship for her daughter. And so she worked with a therapist to actually get the tools on how to do that, right? And in that case, it included, getting a restraining order. Like this is not simple stuff, right? Like this is include getting a restraining order. It included connecting more deeply with her faith community and really, kind of really deepening with her faith community as the folks who could be safe, stable, and nurturing relationship for her. And then also give her a break when she needed a break as a now single mom with her daughter. And I'm going to tell you that 18 months later, that little girl's growth rate was 7 centimeters a year. I'm telling you that the rate at which her osteoblasts lay down long bone, right? Literally her vertical height went from 2.7 centimeters per year to 7 centimeters per year. And all I did, I manipulated the environment that allowed her and her mom to reduce the amount of stress hormones and enhance the buffering care and the buffering hormones. That's what I did. Any doctor in California can do that right now.
Wow, that made my hair stand up a little. Very powerful, that story and example. One of the the things that we've been talking about a lot in our racial equity collaborative across state agencies is the barriers around trust and the challenge of wanting to provide services to communities and communities not feeling safe to share the information about their own experiences with, whether in our case it's government or in this case it will be medical providers. But how is that being addressed in this plan to roll out ACEs screening, and kind of what are the steps? I imagine that this is being addressed in some of the training, but what will it take so that communities and families who are experiencing ACEs will feel safe to share that with their providers?
So one of the things that we included in the provider training, that in order to get reimbursed, so in order for a provider to get this payment, they have to take a provider training, and there's the kind of the basic training that was created in partnership between the Office of the Surgeon General and the Department of Healthcare Services. And fundamental to that training is, hey, you do the screening, but all of this has to happen in a setting of trauma-informed care. And fundamental to trauma-informed care is a recognition and an assessment of how race, bias, discrimination has played out and may be impacting a patient's level of comfort, a patient's what experience they're having, and how we are supporting and responding in a trauma-informed environment. So we have definitely included that as a fundamental part of the training that every provider has to take in the state of California. There are other pieces. I mean, so when I mentioned, for example, that we went to the de-identified screen, what's interesting about that is part of the way that innovation developed was actually a recognition of a couple of things. Number one, I started screening for ACEs 10 years ago and developed doing ACE screening 10 years ago in my own practice. But then I also recognized that if we were actually going to get more and more folks to do it, maybe not every patient would have the level of trust that I have with my patients. And one of the things that was fascinating is that we found that with the de-identified screen, where patients don't have to say which ACEs they've experienced, only how many, that the disclosure rate went up, right? So folks were more comfortable when they recognize that they're not going to be called out, especially for parents of, I'll just say especially in communities of color. That was we found that. So these are all some of the things that have informed this work. Clearly, I think it's a big priority to get to achieve greater parity in the representation of clinicians, right? And the communities that they serve. And that's certainly something that within Health and Human Services, we've been looking at with loan repayment and trying to increase the pipeline of providers. But this is why these are all part of the puzzle in getting to a comprehensive and equitable system of care.
Thank you. And I have another question for you, and then we'll start to move towards wrapping up. But I was curious to know, you've had an interesting career that's taken a lot of turns and done a lot of different pieces of work in that. And sitting where you are now, would you be willing to share a few things that you wish you knew 20 years ago, or that you would tell to your younger self as you were embarking on this path?
Oh yeah, so this is a great question. So when I first read the ACE study, I read the research. I was looking at the health outcomes of the kids and families I was caring for, and I described this in my book. This was a hilarious thing. So I took all the research, put it in a PowerPoint, right? And I got this amazing opportunity to do a presentation for the hospital council. These are all the CEOs of all the hospitals in San Francisco. And I was like, this is gonna be it, man. I'm gonna blow it out of the water with this. I'm gonna take all the information, I'm gonna present it to the hospital council, and they're gonna fix it. And I took got my PowerPoint, went to the hospital council, dazzled them with numbers. I was so rigorous and ironclad, like no one could question any of my data. And at the end of the presentation, I said, so what are you guys gonna do? And they looked at me and they said, Nadine, what are you going to do? I thought, and it doesn't go away, but I thought, and this keeps happening to me over and over and over in the years, right? That I thought, if I tell the right person, if it's the powers that be, I'm gonna tell the powers that be, right? I'm sorry, I have to say this. When our governor was the mayor of San Francisco, I was on the Citizens Committee for Community Development, right? So, I knew lots of his peeps, and we'd been in touch from back in the day, and he came to the opening of my clinic, and so when he was running for governor, I sent a message, through the network, and I was like, hey, what are you gonna do about ACEs? And then he got sworn in, and within his first hours of office, he had issued the executive order, created the role of Surgeon General, and he was like, hey Nadine, what are you gonna do about ACEs? Long story short, the point is that any one of us who's waiting for someone else to fix this, right? We're gonna be waiting a long time. We do this. And I didn't imagine that this would take me to this place, but the change comes from each one of us saying, okay, I'm gonna take this on.
Thank you. I'm going to give you just a moment to think about if there are any other closing remarks that you want to offer. And although that was actually a really great note to end on, but maybe there's more. I want to just respond to a couple of logistics questions from the audience. Also, the slides will be available. We will send an email out with the PDF of the slides to the RSVP list later. So if you did not sign in, make sure that you do. We're also videotaping this, and so there should be a video available. I don't know how long it takes to process and get up, but we'll send a link to that as well. And there were a couple of inquiries about precision medicine. The precision medicine team is sitting in the second row right up here. Wave your hands. So when we finish, if you have questions, you can come and talk to them right there. Thank you so much. This has been really, really fantastic, and I've learned a lot over the course of the last hour and a half. And before we close, I just wanted to see if are there questions that you haven't been asked that you would like to respond to, or just any other closing remarks that you'd like to offer.
I think the only thing that I want to add is just my tremendous gratitude to the people in this room. Not only to you and the HIAP team and to my amazing team with the Office of the Surgeon General, but related back to that very kind introduction, I think that it is easy to kind of look and say, oh wow, here's Dr. Burke Harris, she's in the role of Surgeon General, like this is this will get fixed, or this will get done, or this is, and my gratitude to all you in the room is because you guys know, you guys do this every day, right? You're in it, doing the work, implementing policies, implementing programs every day, and this is hard work, and it is going to require us to break some barriers and break some boundaries. And I'm just grateful for your for your partnership. I'm humbled to be a colleague, and I think that we have a singular opportunity in front of us right now, and we got to take advantage of it.
Yes. Thank you so much. So let's show some love and give a big round of applause to Dr. Burke Harris. And I'd like to be able to, I think I can say that you've got a big crew of people who've got your back. So thank you for sharing your vision and inviting us to join you. Thanks, everybody, for coming.